The third topic is ST elevation, which is significant when it is greater than 1 mm. That means one small square in two or more continuous limb leads, or greater than 2 mm in two or more leads. And it's usually due to the complete full thickness myocardial infarction. And ST depression is equal to greater than or equal to 0.5 mm and greater than or equal to 2 continuous leads, and it indicates myocardial ischemia. Another topic that they can ask you for Viva and last case. T waves are too tall. That means greater than 5 mm in limb leads and greater than 10 mm in chest leads, and it's the same criteria as small QRS complex. So whenever T is really tall, or we call it tented T waves, then you have to think about increased potassium, hyperkalemia. That is a fatal electrolyte imbalance in our body. And the causes for hyperkalemia are renal failure, hemolysis, massive blood transfusion, rhabdomyolysis, tissue necrosis such as burns, metabolic acidosis, Addison disease, and also it can be because of drugs such as ACI inhibitor, ARB, potassium sparing diuretics such as spironolactone, amiloride. It also can be because of NSAIDs, and it can also be because of foods like banana, papaya, and green leafy vegetables. And the normal serum potassium is usually 3.5 to 5 mmol per liter. So hyperkalemia is seen whenever the potassium is greater than 5 mmol per liter. And I'm going to talk a little bit about the management of hyperkalemia. The first management should be, we have to get the ECG urgently, connect to multivital parameter monitor, put a large 4 IV cannula, usually 18G, and send blood for investigation such as full blood count, serum creatinine, serum electrolyte, arterial blood gas, and random blood sugar. And in ECG, whenever we see tented or tall T waves with broad QRS and flat P waves, we have to think about hyperkalemia. So the first management should be to start 10% calcium gluconate 10 ml through a large peripheral vein, followed by normal saline flush. Then repeat after 5 to 10 minutes until ECG normalizes. And this calcium gluconate is given as a cardioprotection of myocardium. And after that we repeat the ECG, and then we have to monitor the blood sugar, and if the blood sugar is less than 4 mmol per liter, we should straight away go for treatment of hypoglycemia. And the next management is to drive the extracellular potassium into the cell. This is our next step. So we start with soluble insulin, 10 units in 50% dextrose in 50 ml, repeated in 4 to 6 intervals. And also we can do nebulization of high dose of salbutamol 5 milligram, but I will be cautious and consider lower doses in patients with ischemic heart disease. And after that, monitoring blood sugar hourly for 6 hours post insulin dextrose, and maintain the input and output chart to check the volume status of patient. Also we can check serum electrolyte and blood urea to see if the patient is going in acute kidney injury. We can also do ultrasound scan to exclude any obstruction of the kidney. And also if the patient is on ACI inhibitor or ARB, hypertensive patient, then we can change it with calcium channel blocker. And Also, we have to advise the patient to start low potassium diet, avoid alcohol, fresh fruit juice, and king coconut water too. And we also have to do arterial blood gas, and if there is acidosis, then we can give 8.4% sodium carbonate is given. And also we can start with calcium resonin, the potassium resins, because it reduces the absorption of potassium. And in follow up, we check the serum electrolyte after the treatment and the blood sugar as well. And still, if the potassium is high, then we have to go for nephrologist's opinion and consider doing dialysis. Thank you.